So this is edema. And we're in here. Now this is a reminder from what we had in physiology actually about flow in the capillary, and on the arterial end, hydrostatic pressure is higher, and it pushes fluid out into the interstitium. And on the venous end, the tissue pressure is actually higher than the venous hydrostatic pressure, so it pushes it back in. Also, you have some other factors working, like oncotic pressure that's caused by the colloids in the blood. The main one is albumin. Now, this is the normal process. You don't push out more than the lymphatics can handle, and push, and of course, receive it back on the other end. So, there are some factors that can influence this that would cause problems to occur, and you would put more fluid in the interstitium than you could actually absorb through the lymphatics or put back into the circulation. One would be the increase in hydrostatic pressure on this end. That will do that, or actually throughout the capillary bed. That can happen, and we'll discuss that relative to heart failure. You could have a decrease in the coronal oncotic pressure, which means more fluid will leave the vessel in the beginning. And liver disease, things like that can cause that. You can also have increased vascular permeability. That's due to either an anaphylactic reaction or maybe some bacterial problem. And then lastly, you do have blockage of the lymphatics themselves, which can be caused by a tumor, or if they don't hook up right genetically in the beginning, then you can get edema too. And that's just those things we just said as far as causes of edema. And this chart kind of goes through these things. It actually lists disease examples over here for the problems that you have. And read through that and see what's a good example of what. Okay, so let's start out with the increase in hydrostatic pressure. This is the kind of thing that happens when you have heart failure. This is the arterial end, and this is the venous end. Now, when the pressure is higher, then you get more pushed out than the lymphatics can absorb, and it remains in the tissue, so you end up with edema in the tissue. And this is just a chart showing heart failure and how that contributes to it. The easiest way to look at this is just to look straight down and see what happens. Of course, when you have cardiac failure, you do have decreased cardiac output. And then effective arterial pressure is going to drop, which leads to increase in renin. And by the way, what's this whole system called? When you decrease perfusion like that, especially of the kidney. Got three initials. And the first one is renin. System. Okay, so renin gets into play, and you're doing that to try and cause increased vascular constriction so that you can actually boost the pressure. And here's the aldosterone that occurs along with this, which is actually coming from the adrenal, not the kidney. But that's causing sodium retention, and the net effect is to raise, what you're trying to do is raise blood volume and pressure, but that actually ends up causing increased pressure, forcing more fluid out into the tissue. So that's the main thing that's going on. And you do see some side effects that are occurring. For instance, malnutrition can have a big effect. Remember, I told you there was this thing called cardiac cachexia when you don't have enough perfusion for the tissues to receive adequate energy stores. And in that situation, that just contributed to it. That contributes to the heart failure and also the type of metabolism that you have going on, which would be the anaerobic kind of glycolysis. And of course, this is showing more of the renin-angiotensin system and all of that stuff that comes in as compensatory mechanism. So that's essentially what's going on to make the edema. So what's it look like? Here's an animal that actually has ascites as a result of heart failure. Which side is found to failing here, right or left?
If there's ascites, it would be the right.
Right, usually. Now, that doesn't mean that in the left side of heart failure you can never get ascites. Yeah, you can. But the most common thing to see that with is with the right side of heart failure. Now, as far as the left side of the heart failure is concerned, where would you expect to see most of the fluid there? Lungs. And also pericardial sac in the chest, basically. And here we go. Here's this nice big heart. And there is some fluid in the lungs. So if I have right side of heart failure primarily, or if I have both, I'm going to get fluid in the lung. But if I do get have right side of heart failure, will I eventually get some left sided failure?
Eventually.
Yeah, eventually you will, because over time both ventricles have to pump the same volume. Now, if the right is failing and continues to fail over a period of time, then the left is not going to get enough. So you're going to go in the left side of heart failure as well. Now, where would the most acute lesion be if you got right side of heart failure that is a predominant thing? Where would the most acute lesion be? In the lungs or in the liver? If it's primarily right side of heart failure, where's the most acute lesion?
Lungs.
Because the left side is going to fail after the right side has failed for a period of time. So the lung is actually going to be the one with the most acute lesion. So you do see some edema accumulating in the lung here. And then, of course, you can have biventricular failure. In other words, both ventricles are failing equally at the same time. So the stuff that we see that indicates big heart, the amount of intercostal spaces that are taken up here. One of the things you can't really see here is what they call the anterior cranial cardiac waste. And that's what's in the medius down here. Since this is cut off, you can't really see it very well, but that's reduced in size because the heart is expanded into this area. Cardiac, yeah.
Sorry, you said anterior cranial cardiac waste?
Anterior cranial. Depending on how you want to look at it, in anatomy, what term do we use for most forward most of the time?
Cranial.
We use anterior in veterinary medicine. Now, what do they use in human medicine mostly?
Anterior.
Cranial.
What? No.
No? Are you sure you're the other way around?
Yeah.
The other way around? So, you can call it by either one, but depending on which one you're talking about, veterinary or human. But it's the shadow in front of the heart is the one we're talking about. Oh, you guys did learn something. Most of the time, when I ask you something about anatomy, you're what? You know, you did seem to understand what that was. Okay, and the coronal is back on this end, and this usually gets affected too by things like edema, which decreases the amount of lung shadow that you see back here. Also, as the liver enlarges, it pushes the diaphragm forward, so you reduce the area that's there. That's a big liver in this case.
Dr. Grant,
Mm-hmm.
I just got a little confused. When you said, because normally I thought with right-sided heart failure, you're going to have more edema in the liver because everything's going to get...
Yeah, well, right side of heart failure, the circulatory system behind the right side is going to experience the problem first.
Right. Okay.
So if I got right side of heart failure that's been there for a while, what's the liver going to look like? Acute lesion or chronic lesion?
Right.
Now, as the right is failing, the left will also start to fail. But that's gonna happen after the right has already gone through a significant amount of failure.
Okay.
So back up then to the where? Lung. So the most acute lesion, if I got both of these ventricles failing, unless they both fail at exactly the same time, is going to be in the lung. In that case, with right side of the heart. Okay. And again, big chest. And this is a dog. You can see this barrel-shaped chest even more here. Remember I showed you this morning about this kind of shape to the chest in a cat? Because normally a cat's chest is a very acute angle like that, but that one was kind of spread out. The dog even does more because the dog is more barrel-shaped in the beginning. So this is another indication of heart failure. And this is showing the same kind of thing. Here's a very, very large heart. Here's the liver. So where did the failure probably start on this? Right, because this is a chronic one. That's actually a nutmeg liver, which is the one that has the connective tissue and stuff in it. So. And we would have some fluid in the chest because the left is also failing, and we would have some fluid in the abdominal cavity, of course, because of the liver and the back up on the venous side. Now, this is showing a normal heart, and why it's showing this is it wants you to, well, what the author is doing is trying to get you to look at the base of the heart. What's this thing that goes around and the valves are attached to it? Don't tell me he didn't tell you that. He told you that too.
Can you repeat the question?
What?
Can you repeat the question?
Yeah. What is this thing that goes around the base of the heart that the valves are attached to?
It's not papillary muscle, right?
No.
Coronary.
Say it again. The annulus fibrosis. Okay. Now, what would happen if I got a lot of connective tissue expansion occurring or stretching because this heart got so big? What would happen to the valves?
They would stretch out.
They would stretch out. The valves are not going to grow anymore. So what would I get automatically? Regurgitation back through the valves? Okay. So in a really big heart like this, that increase in the annulus fibrosis, well, stretching of it really, it's not really increasing, but the stretching the annulus fibrosis results in unseating of the valves. That's the term they use for that. Because what's actually happening is you're pulling the valve leaflets apart, and they don't shut properly. So you would get regurgitation doing systole or doing diastole. Systole. And what kind of murmur would I get? A diastolic murmur or systolic murmur? Something might be sticking just a touch. Okay, this is a case of heart failure too, but this is in a steer that was out in the west. So well, this one had a congenital heart problem. That's why he had the nutmeg liver, and of course he would have had ascites and that. But what happened to this guy?
Brisket.
Yeah, brisket disease. That's a nice term to use if you know what it means. Not just say brisket disease. Or when you see them, he dead. Yeah. So what causes it? Heart failure. Now, how did that come about? Somebody said high altitude. Yeah, right. What happens is these animals are kept down in the valleys during the winter. Why do you keep them down in the valleys during the winter? Because it's what down here? Warmer. Okay. Now, in the spring, they will take these guys up to the meadows in the higher altitudes, and when they go up there, they're not adjusted to the lower oxygen tension that's in the atmosphere up there. So that does cause the problems that you see, primarily problems in the lung, and that causes an increase in the workload on the right side of the heart, pump it through. So you end up actually getting right side of heart failure in there. And it backs up on all sides of the venous circulation, including the jugular furrow, and of course it accumulates down here because fluid is going to gravitate. It gets into the brisket, and of course it would be in the abdominal cavity and so forth too. So this is high altitude disease. That's another name for it. So, from what you know now, what's acute and what's chronic? Looking at these plates. That's the same, and that's the same. So, which one is acute and which one is chronic? The one on the right. My right, your right.
Both rights?
Come on, Simple, both ain't the answer. So which one?
Right. It's chronic. Our right is chronic.
Your right is chronic.
Yes.
Not right. The liver, yeah, the liver.
Yep, your right is chronic. And how do you know that?
Not right.
Nutmeg.
Nutmeg? Where's nutmeg found? In the lung?
Liver. In the liver.
In the liver. So what are you looking at?
Just the one.
You're looking at the lung.
Oh.
So it's not nutmeg. So what is this pigment that's accumulating here? This brown, golden brown pigment?
Iron. Iron.
Iron, right. So what do we call this? Hemo what?
Citron.
Hemo, yes, hemosiderin. We just had pigments and went over this stuff. And went in one end right out the other. Okay, so this is hemosiderin accumulating in the lung, and that's a more chronic change. This is, well, first of all, is this the same species?
No.
What's this? What species is this? And what is this?
Mammal. Something else.
Canine. This is canine? Yeah, that's the canine. And this is the what?
I'm gonna go with cow. A non-canine.
That's
Cow.
not a feline. Feline don't have. Well, marcated lobules like that. What else else marcated lobules like that?
Cow. Pig.
Cow. Okay, or bovine. Because if you just say cow, what does that mean? The female of the species. And bulls have the same kind of lung. Okay? All right, so this is very acute, and that's just the edema fluid there. You can see it separating the lobules here. Okay. Now, this one is due to increased vascular permeability, and that can be seen with anaphylaxis. And it also can be seen with other kinds of things too. Suppose I was in Arizona, and out in Arizona, I walked in my backyard and I heard something say, like that. What was that? Probably making that noise. A rattlesnake. And he bit me. So can this cause? So can that cause increased vascular permeability, the venom from the snake? Oh yes, it can. So there are a number of things that can cause this. Anaphylaxis is one thing, but you can also get this as a result of toxins such as snake venoms. But anyway, when you increase the permeability, you get more fluid going out than you can absorb in the lymphatics, and that's the situation there. Okay? And this has occurred in this case, and this is subacute edema that is all over the entire body. And actually, that one was due to a bacterial toxin causing increased permeability. And same kind of thing in cattle. And what this is showing is the tail that's split open so you can see it. And there's just a fat tail here, but this is where it's cut open and you can actually see the edema fluid in the subacute. Now, you can have anaphylaxis too in this kind of situation, or inflammatory kind of edema. And this is a very acute case that occurred in this cow. That's the gross, and that's the histologic. This is an acute edema, which you would expect to see actually in anaphylaxis. What happened in this case is that it was associated with a liver abscess. And you can see that on occasion. What happens there is the sensitizing part of this comes as a result of the abscess leaking into the venous system. A little bit comes out, the body forms antibodies to it, a little bit more comes out, and then you get a rupture, and what happens at that point in time? All of this antigen floods out, and you've already sensitized a bunch of cells out there to this. So they react, and you get this massive histamine released, and fluid all over the place like that. So this is anaphylaxis, and that one was associated with the liver abscess, actually. But what else can this be associated with? Say in a cat. What else can this be associated with? Remember the cat that was having difficulty breathing? What did he have? He had asthma. So now what exactly was the antigen there? Could have been anything. From kitty litter to whatever else he came in contact with. And of course it can be due to reactions to drugs as well. Okay. And this one, you see fewer dots in here because that's a decrease in the oncotic pressure. And what could do that? Cause a decrease in oncotic pressure? Liver disease? Something else?
Shock. Not shock.
Well, yeah, shock could actually do that too. Especially if it's anaphylactic shock, because when you get increased vascular permeability, you're going to leak this stuff out too, which is just going to compound the problem.
Parasites?
Parasites? Yeah. Parasites? There's one other one too.